Uh, Wish you all a very, very good morning. And I would like to thank the organizers of Periavlokan for having invited me over to share my thoughts and give some tips regarding soft tissue aesthetics around dental implants. We have to understand, as more and more people are practicing dental implants, we have to start saying that it's very easy to achieve the white aesthetics. That's what is there in the hand of your laboratory technician. If you select a proper shade, you can achieve very, very good aesthetics. On the other hand, when it comes to pink aesthetics, when it comes to managing the soft tissue on dental implants, it's purely a question of skill. It's all in your hand. And that's where we as periodontists come into picture. And that's where our strength lies. The way we handle the tissues is very important to achieving and giving wonderful soft tissue aesthetics. A little bit about our center. This is where I practice, and it's run along with me and my wife. Our primary goal is doing perio-restorative dentistry, implants, and everything else under the sun. Before I proceed on my presentation, this is a disclaimer. This lecture is not sponsored. All the cases presented here are operated by me, and we haven't done any photo editing apart from cropping them to fit the slides. What I'm looking at as a clinician and as an individual, every time I restore a tooth, I want to see to that it looks natural. Okay, no one should be able to make out that a tooth in the mouth has been replaced. Probably if I see the same patient after a few years, I should start hunting out which was the tooth that I replaced. And that would be the most successful thing for me, whether it is a 2-1 in that case, whether it's a both canines in this case, whether it's a both laterals in this case, or whether it is 1-1 and 1-2 in this case, or whether it is 1-1 and 2-1 in this case. We want to see teeth that look beautiful, not just in color and form, but also with the kind of soft tissue envelope or the drape that we see around this. We want to see this consistently around all these areas. And here where our role as periodontist comes in, managing the soft tissue around dental implants. Before going into depth, let's understand 3 terms. I'm pretty sure you all know about these. There's something called the gingival biotype. It is classified as thin, medium, and thick. And there is something called pigmentation that can mask either of 3. A thin biotype is when classically told where you can see the root of the tooth through the gingiva. A thicker one is where you just can't see until you see classical, wonderful, heavy stippling. And there is something in between. The easiest way to identify whether you have a thick, thin, or whatever kind of a biotype is do this test. Take your graduated probe, slide it down the gingival crevice and see whether you can see the grayness. If you see the grayness of the probe, then it means that the gingiva around is thin. If you don't see it, it means it is thick. And if you see a haziness, then it is medium. So that's the easiest and most immediate proof to identify what is the biotype of this patient. But however, you have to understand this technique will not tell you the exact thickness in millimeters of what thick or how thin is the gingiva in millimeters. The other term for us to understand is a term called as periodontal bioforms. This is a term which this is described as a distance between the tip of the interdental papilla to the gingival zenith. If this height is equal to 4 millimeters, then it is known as a normal bioform. If this distance between the tip of the interdental papilla and the gingival zenith is more than 4 millimeters, then it's known as a high bioform. And then if this distance is lesser than 4 millimeters, then it is known as what we call as a flat bioform. As a general thumb rule, flat bioform is usually associated with squarish teeth and thicker gingiva, or what we call a thick biotype. Norm, that is 4 millimeter, is usually associated with the medium biotype and a trapezoidal teeth, whereas when you say it's a high bioform, then it's usually associated with triangularish teeth and thinner biotype. Next, we have to understand that what is the difference or similarity between the tissue around the natural tooth and the dental implant. Why is it so important? Though both of them look very similar, we use different terminology. The tissue around the natural tooth is known as gingiva, whereas the tissue around the dental implant is known as what we call as a peri-implant mucosa. Okay, why we say so? We say so because the peri-implant tissue is not attached to the implant surface. It is closely adapted. However, the tissue around the natural tooth is attached. It's a part of the human body and is attached to one more part of the human body called the tooth. Either it's attached to the cementum or cemento-enamel junction or to the bone. Whereas around a dental implant, we have fibers running from the bone into the tissue, but there is no attachment. There is no biological seal, 100% biological seal between a peri-implant mucosal epithelium or the connective tissue and the implant surface. And this can be attached and detached every time you place and remove a component. Whereas around the natural tooth, you cannot do that. You can sever the attachment using a blade, but you can never ever detach it. Okay. Apart from that, as a physiological nature, the tissue around the natural tooth is healthy gingiva, whereas the tissue around the dental implant is a scar because there is no attachment. And as you all know, the scar tissue keeps on shrinking and contracting. For example, if you had a wound during your early childhood and you had a scar there, you would notice that as you aged, the size of that scar has become smaller and smaller and scar tissue shrinks. Exactly the same thing happens to the mucosa around a dental implant. If I had a 3 mm tissue thickness around a natural tooth, it will remain 3 mm 10 years down the line. Whereas around a dental implant, if I've had 3 mm of soft tissue thickness, it can end up becoming 2 mm or 1 mm over a period of time because there is no functional stimulation to this bone. Every time I eat around a natural tooth, the fibers get stretched, the teeth goes in, comes out. There is a stimulation, there's formation, resorption, collagen fiber remodeling. Whereas around a dental implant, the implant doesn't go in and out. It means it's a failure. On the other hand, the mucosa is only bearing the functional forces. It is the reparative capacity of a peri-implant connective tissue as well as the epithelium is far lesser, so it keeps on contracting. Okay, and that's why it's very important for us to understand on day one itself that I have to have adequate amount of soft tissue bulk around my dental implants. Okay, and this was illustrated by Berglund et al. In a very classical manner. They found a very simple study. They put implants, they chopped out the soft tissue. And when they checked these sites again after chopping the soft tissue, they found that if you had a soft tissue thickness of 2.1 millimeters, if you have 2 or 2.1 millimeters, then even after chopping the soft tissue, if the remaining tissue was 2 millimeters or more, then you never had crestal bone loss. The bone level remained the same around a dental implant. On the other hand, if you had a case where you ended up trimming the soft tissue and this thickness of soft tissue became anything lesser than 2 millimeters, if the soft tissue thickness was lesser than 2 millimeters, then you lost the bone. The tissue resorbed the bone to accommodate that additional amount of tissue. And that's why you start seeing what we call as bone loss around these dental implants. Okay. In the older generation, when we had these machined implants, this bone loss was what we call as very classically staying down at the first crest. It remained there at the first thread. Whereas around the current modern day dental implants, if you start seeing crestal bone loss, okay, and because the implant surface is entirely rough, the rough surface gets exposed to the outer environment as you see here. And if it gets exposed, then you can have a progressive bone loss. Around the machine neck, machine collar implants, if you have 2 mm thickness and if you lose the soft tissue, it can settle down 1 thread below and stay stable for the rest of the life. Whereas around the rough surface implant, if you lose bone at the crest, because the roughness of the implant surface, the tissues will start going down and then you are creating an invitation for bacteria to contaminate this rough surface and then lead to continual bone loss around the dental implant. So you move from peri-implant mucositis to peri-implantitis. And that's why it's imperative, it's absolutely imperative that you have more than 2 millimeters of soft tissue thickness, buccolingually as well as vertically around your dental implant. Okay. And depending upon the native amount of bone thickness available, either you will see a horizontal bone loss or you see a vertical bone loss. So if you had the peri-implant bone, if it was less than 1 mm, when you lose the tissue, you will see a horizontal bone loss. If the peri-implant bone on either side was more than 2 mm, then you will end up seeing an angular bone loss. The next thing is soft tissue is aesthetics, and that's what we are looking at. What I'm looking at soft tissue around every dental implant placement that I do, I need to see the same 7 parameters what I see around the natural tooth. I want a healthy contour. I want a good thickness. I want the levels of the soft tissue on my dental implant same as around my natural teeth. I want a proper scallop. I want a good healthy stippling, because stippling around the dental implant is very key. If I don't see stippling, then it means that there is some disease process there. Okay. Then I want to see papillae. Developing a papillae between 2 dental implants is very, very tough, highly skilled job, but yes, it can be done. It needs a bit masking, but you can do it. But the only difference is around a dental implant, the papillae will be there, but it will never be as sharp because you do not have the interdental bone, inter-implant bone, which is coronal. Inter-implant bone is usually at the same level of the implant. So you'll always see a flattened out papillae as compared to between 2 natural teeth. And I want to see a proper scallop so that when my patient smiles, I actually see a natural looking restoration and tooth as compared to what we call an artificial flattened or a colored gingiva. Coming to when we want to intervene to managing the soft tissue. When would I intervene to manage my soft tissue on a dental implant? Let's look at this point. 1 second, there's some reason why the slide is stuck. I'll just play it down here. I can manage the soft tissue around the dental implant either prior to extractions. For example, if I have a patient with a lot of inflammation coming in and I know I have to remove the tooth, I would rather do the scaling, see that the gingiva has become healthier, and then I would do the extraction and then the implant, etc. I can do soft tissue procedure at the time of implant placement. I can do it at second stage, and I can do it even after restoration or even after a few years after an implant placement. So you can intervene at any point of time during the entire treatment protocol to get an ideal soft tissue outcome. How would I classify the soft tissue procedures? I would put them on 2 sections. One is based upon the nature of the graft. The nature of the graft can be either a pedicle graft or a free graft. So when I'm harvesting a graft, this graft can be connected to the source, then that becomes a pedicle. It can be a free graft. If I'm taking out from one area and sticking it up elsewhere, then it becomes free graft. Also, both of these types of grafts can be epithelialized or they can be de-epithelialized. So I can either use only connective tissue pedicle or free connective tissue. I can use a pedicle epithelialized or a free epithelialized. And based upon the surgical procedures, these are the various soft tissue procedures. I would do a palatal rotation flap, apical position flap, a pouch and roll, a vascularized interpositional graft, pouch and tunnel, and layered. So what do we mean by epithelialized pedicle graft? You see here on the top, you have epithelialized and de-epithelialized. Both of them are pedicle. They're connected to the base. Whereas this is a free gingival graft, also known as epithelialized free graft, or a connective tissue graft, or a subepithelial connective tissue graft, the way you want to call it, is only connective tissue and no more epithelium on that. So you can have free as well as pedicle. Both of them can be epithelialized or connective tissue. This is an article which I wanted to just screenshot and remember. The lines which are absolutely written in red, which I've highlighted it in red. This is from the Osteology Symposium consensus conference. Okay. Autogenous soft tissue grafting to promote peri-implant soft tissue health or marginal boneless at implant site with insufficient soft tissue dimensions have to be or considered. Connective tissue grafting procedures to promote greater stability of interproximal bone layers. So understand, when we graft a soft tissue, I'm not only increasing the quality of my soft tissue, but I am increasing what we call as the stability of the marginal bone around dental implants. On the other hand, it's also important for us to understand that the keratinized tissue what I have around a dental implant facilitates hygiene and plaque control. So it's imperative that you have more than 2 mm of keratinized tissue. It enhances plaque control, because you remember, by any chance when you're brushing your teeth, if you see that the brush slips and the bristles hit the alveolar mucosa, how badly it hurts. So imagine a patient who doesn't have keratinized tissue, then you end up with what we call as a very injurious tissue, and that's how once it starts hurting, patients do not maintain hygiene, and then that leads to further deranging changes. On the other hand, this is very important for us to understand. A very classical article by Kato and Nakano, published in the Journal of Prosthodontic Research. What they found here is this. The thickness of peri-implant soft tissue is essential because a change in soft tissue margin level tends to be affected by thickness of peri-implant soft tissue rather than bone width. So what they did here was, when they were studying the samples, okay, irrespective of what was the actual bone width on day one, whether you had 6 mm or 4 mm, the bone level or the bone thickness was determined by the amount of soft tissue. So you could have had a 6 mm bone, and if you had a thinner biotype, you lost more bone. On the other hand, if you had 4 mm bone and you had a thicker biotype of the gingiva, then you always maintain that bone. So it means that there's a soft tissue that is actually guarding the underlying bone level around the dental implants. Now, how am I going to get the best outcomes of soft tissue around my dental implant? Is by this. These are my flow chart from top to bottom. Lesser the intervention, better the outcome. So socket shield or partial extraction therapy gives the best soft tissue outcome, whereas when you do complex augmentative procedures, multiple surgeries, you also have what you call poorer outcomes. So faster the surgeries, faster the interventions, smaller the surgical site, better is always the outcome. So let's look at this case, socket shield of a maxillary canine. You can see the canine was broken in this individual. You can see stippling around that site. So we decide to do a partial extraction therapy or a socket shield, what is more commonly known as. So we remove the tooth, leave the labial portion of the tooth in situ. And when I'm leaving this root piece there, the labial shield there, what I am doing is my entire labial tissue here is gingiva and not peri-implant mucosa, because I have the cementum, I have the periodontal ligament fibers attaching onto the cemental surface. So the overlying mucosa that you see on the labial side is actually peri-implant mucosa. No, it is gingiva. The peri-implant mucosa is only on top of the mouth of the implant. So then what I do, I put a Teflon there, I put a temporary abutment and customize the healing abutment and leave it. My patient goes back like this. 3 months down the line, when the patient comes back for fitting, what I see, are very wonderfully healthy, because this is a tissue, what you see on the labial is untouched, it's virgin. I put my final abutments and then I stick in the final restoration for this patient. This is how it looks on day one. The surface stippling, what you see here is the same. It has never changed because the root is there, which is maintaining a viable periodontal ligament. So my peri-implant mucosa around this canine is as good as it was around the natural canine. And that's why I get the best possible outcomes here. So the gingival zenith on 2-3 is as good as that's on 1-3. The emergence is wonderful. The peri-implant tissue health is fabulous. And that's what I want. What I see is what I get. I want to see a beautiful contour, a very healthy tissue. And what I did, I actually, as a clinician, didn't do anything. I just did not touch the soft tissue. And that's the best thing you can do. Without touching, you get the best outcome. And that's what you want, a fabulous outcome without doing any intervention. And that's what you want. You see a beautiful stippling around this tooth, and this outcome is going to last the life of this particular patient, or as long as that particular implant is in function. And that's why when you're not doing anything is the best thing that you can do to your patient to get the best soft tissue outcome. However, it is not always possible to do this. And that's when we start looking at additional procedures. There are times when you do an immediate post-extraction implant placement. Okay, so let's look at this. If you cannot do a socket shield for whatever reason, then doing a conventional immediate extraction and immediate temporization with good stability is the key. Because every time you put an immediate temporary on those implants, you guard the soft tissue. Because the soft tissue gets supported at the top by this temporary. And that's what you see when the patient comes back at the end of 1 month after the implant. You see the soft tissue looks good. There's a beautiful papilla that is still there. At 3 months, it looks nice. So by the time I restore up this case, I'm using the temporaries as an impression coping. And when I finish and restore up this case, I still get a nice contour around my teeth, around the implants, and the peri-implant mucosa looks very, very nice, neat, and healthy. And I have a papilla. I have a proper shape, I have a decent stippling, and I have a decent amount of bulk around these dental implants. So if you cannot do socket shield, the next best thing that you can do to have a beautiful soft tissue is what we call as a immediate post-extraction implant placement. It saves you a lot of headache. Understand, not doing anything is also doing something great. And also very importantly, you place the implant at the right location and you guard the inter-implant bone, and that's why you have the papilla. Next, if it is not possible for one to what we call do an immediate post-extraction placement the conventional way, something like this in these cases, then you have to manipulating this case. Let's see two situations here on the same slide. On the left of this one, you have a fractured 2-1, and on the other side, you have fractured 1-2. We have the implant going in 3D position. I know the proper depth of the implant placement, but however, I have to do a GBR. You see the amount of bone that is lost on this tooth is too much. I need to do a proper GBR on this case, whereas on this case, I had an excellent implant placement right in the proper location. It was a conventional implant placement because the tooth had a vertical. You couldn't do a socket shield there. We do a GBR, put a graft, put your membrane. And then what we do is we rotate the palatal flap. You do a palatal pedicle. Now, if your implant is stable and you have to graft, you cannot leave a graft uncovered, and that's why you have to do a primary closure. Doing a primary closure around an extraction socket is a very, very difficult thing. So what you do is either you advance the buccal flap or you rotate the palatal. If you advance the buccal flap, you're going to pull the entire mucosa down. You're going to stitch it against the palate. And what's going to happen? You're going to change the level of the mucogingival junction. As you advance the flap, you change the level of the mucogingival junction. Instead of that, if you rotate the palatal flap like a pedicle, okay, and seal it the way you see here in the picture, what you achieve is you are not touching the mucogingival junction. There's no flap advancement, and the socket also gets sealed. This is epithelialized pedicle, and 3 months down the line, you see that the tissue around both of these implant sites heals very well. There's no change in the buccal tissue level. It's only the palatal tissue that's covering up your extraction sites. And by the time we end up restoring up these cases, that's what you see. You see a very, very healthy soft tissue because the buccal soft tissue was not changed. You would observe that the mucogingival junctions on both of them are absolutely fine. Okay, the gingival zeniths look good, interdental papilla, between the implant and the natural teeth look good, and that's what we want. We want a beautiful looking hard and soft tissue outcomes around these implants. So what we did, we used epithelialized pedicle grafts to cover these extraction sockets, epithelialized pedicle grafts. One of the other techniques to achieve soft tissue outcome is hard tissue grafting. You cannot discount the role of hard tissue grafting. Okay, there are times when we place the implant in the right locations. As you can see here, the implant has gone well, but you do not have ideal contour. You see there is always a buccal depression. Now, you can do a soft tissue augmentation to a certain extent, but soft tissue augmentation sometimes shrinks. So it cannot, at times it may be unpredictable. So if there's a hard tissue deficiency, then you do a hard tissue graft. So now in this case, when I'm doing a hard tissue graft, it is known as a contour augmentation. The implant would survive without this. But what I would not get is an ideal aesthetic outcome. So to get an ideal aesthetic outcome, what you do is a contour augmentation. This contour augmentation can be done with the graft materials which resorb very, very slowly, a dense graft material. So when you use that and cover up, the graft material gets encapsulated, does not resolve. And as the time you go and restore up this case, it holds up the contour and the shape. So now here we have achieved soft tissue contour by doing a hard tissue graft. Okay, so what we did, I didn't have to play much around with the soft tissue. There's no soft tissue graft done, but to get the ideal soft tissue contour, to get the ideal soft tissue aesthetics, I had to do a hard tissue graft, and that's important. So you have to manage hard tissue to get an ideal soft tissue. The study shows us that the soft tissue maintains the hard tissue level, but to get to that level, you need to have a good amount of hard tissue. And that's what you would see here. As we grafted the hard tissue, the bone is now completely integrated, and you see a huge amount of bulk of soft tissue or bone around these dental implant. Okay. Yeah. The next set of cases is where you have to do a simultaneous hard and soft tissue graft to get better aesthetic outcomes. Let's look at this case. It's 2-1, which is an ankylosed and resorbed root situation. It needed a bit of aesthetic work, some DSD planning there. Okay. So what you see here on this CBCT is there's just a root and a gutta-percha that's present in the bone. We removed whatever remaining was there. Traced down the GP, took it out. Then we have the implant going in. We harvested some bone from the adjacent site to do a bit of GBR there and some slow resorbing graft because it's more like a contour augmentation rather than a GBR around the open implant threads. Okay. Then we used the membrane along with the periosteal suture to hold it down so that the graft or the membrane doesn't move around. And then you advance the flap and you close it. Okay. 3 months down the line, when the implant's completely integrated, okay, that's how it looks. On the peripheral radiographs, you see the root, the cleaned out socket, and then the implant along with the resin bonded bridge onto the implant. 3 months down the line, when the patient comes back, you remove the RBB, and then you see the site. What we see is there is still some amount of contour deficit. So as I'm opening up the implant site to replace the restorative work and change it to a definitive restoration, what we do is you open up and you take this piece of tissue, what you see there. You take the tissue, you de-epithelialize it, and you tuck it underneath the buccal flap. Okay. So as you tuck it under the buccal flap, you are now using what you call a free connective tissue. So you take the entire epithelium and the connective tissue, you remove the epithelium, de-skin it, and then slide it underneath the buccal flap. And as you slide it under the buccal flap, you now have what you call a connective tissue graft that's present between the implant, the bone, and the buccal surface. Go ahead and temporize it. And as the tissue matures, as the connective tissue matures and bulks up, as it heals up, you start seeing beautiful healing around the temporary restoration. This temporization process was probably for around 3 months. And now, by the time you come to do a final restoration, you see beautiful soft tissue around this abutment. And you see a beautiful contour. The shape on 1-1 and 2-1, the contour shape is identical. And by the time I finish the restorative work, that's what it looks. What I see is a beautiful tooth, a very, very healthy peri-implant mucosa, very similar to the healthy gingiva around 1-1. Okay, and you can even see wonderful stippling and ideal soft tissue contours. That's what we want. Every time you want to do a soft tissue, you want to get a soft tissue outcome. Also, you would notice here that the emergence, the way the tooth is emerging out of that implant socket looks as good as natural tooth as the adjacent contralateral central incisor is. And that's how it looks on the CBCT. You can see the graft and the implant and stable bone levels are on the margin of that implant. Let's look at one more situation. You can do the free connective tissue graft either along with at the time of implant placement, or you can even do it at a later date. Now let's look at this case here, what we have. Free connective tissue graft along with implant placement. Yeah, this is a missing 1-1. You can already see here that after the extraction of this tooth, I don't know whoever had done the extraction, had compressed the socket. You can even see fingerprints of the guy who extracted it. Okay, every time you compress the socket, that's what you would see. You see the scar tissue, the connective to as the socket heals, it pulls the soft tissue towards itself, and you can see literally pulled tissue at the crest of this socket, or the site rather. Let's go to the next slide. And some troubles with the slide changer on the keynote. Just give me a minute to settle it down. Yeah, that's how was the bone prior to implant placement. It was adequate enough to get the implant in. So we did the implant. Some threads were exposed, so some bone graft along with that. You will always see that the implant goes in ideal 3D location, apicocoronal, mesodistal, buccolingual. All the exposed threads were first covered with autogenous bone. You don't use a dead bone against a naked thread. If you have naked threads, then it should be always and always layered with native bone, autogenous bone, and then followed by any graft material. Once that was done, that's the autogenous bone that went in. And to protect this graft along with the membrane, we use a piece of connective tissue or underneath the buccal flap to close it down. When the patient comes back for uncovering 3 months down the line, what we see is this: temporize, and as you temporize, allow the tissues to heal down, and then you put your final restoration. You can see that even at the time of final restoration, you see two thin, fine scar lines, and I'm expecting that these would eventually settle down over some amount of time for the patient. What I'm happy is the amount of bone that I have around this dental implant. I'm pretty sure that this would eventually hold up. So we did the connective tissue graft along with GBR in the same sitting. So it was implant placement, GBR, and connective tissue at the same time. And that's how she looks right now. Next is again a central incisor, but this time a 2-1. You again see that this site, 2-1 site, is pretty scarred with multiple surgeries that's happened there. We had a cyst there where the implant was placed, cleaned up, and the implant was done. First the cleanup was done, then waited for 6 months, and then the implant was not placed into the cystic site. This is at the time of implant placement. You see the implant's gone in well in the ideal 3D location: buccolingual, mesodistal, apicocoronal. Now, to enhance the amount of soft tissue and protect the bone, if you go back to the slide, you see that the amount of bone present on the buccal of the implant is okay. Now, the consensus statement stated that it's very important to have adequate amount of connective tissue and soft tissue thickness, and this soft tissue thickness would in turn guard the amount of bone that's available. If I had 4 mm and thin tissue, I would lose bone. But if I have 1 mm of 2 mm of bone and I put a good tissue, then I would guard my bone. And exactly that's what we did. So what we did was we did a palatal pedicle connective tissue. You can see that the connective tissue from the palate, it is not detached, and it was taken all around the buccal surface from the palate to the buccal. Instead of a cover screw, we put a healing abutment and then sutured it up. So now what we have a pedicle connective tissue, and the advantage of having the pedicle tissue is it carries its own blood supply and it doesn't involute. A free connective tissue at times can involute, whereas a pedicle tissue would never involute because it's carrying its alive blood supply. And you see that though some amount of the healing abutment that you see is exposed, by the time patient came back for suture removal 15 days down the line, the tissue has covered up. Why? Because the connective tissue is alive, it was carrying its own blood supply, so there's no deficiency of nutrition, and the epithelium then grew over this connective tissue that was there, and that's why you see a primary closure at the end of 15 days, though you didn't have it on the day you actually sutured it. 3 months down the line, you now have excellent soft tissue there, but I still wanted a better contour, so now I do a palatal roll flap. So what I do now is I move some more amount of tissue from the palatal to the buccal. So I make 2 small release incisions. I de-epithelialize the buccal surface, tuck it underneath the flap. This is how it looks probably a month down the line. Healthy tissue, a nice contour and shape. Though there are small scar lines, I'm pretty sure they would settle down over a period of time. And then we deliver a nice looking crown. Though the white aesthetics is not very good, but it looks more pleasant in the patient's mouth than on the screen here. So that's what we want: a good soft tissue thickness, healthy bone level, healthy implant, and you see that this is what we want. Every tooth that you replace should look natural. One of the things what we look at when we're looking at soft tissue is that time. A very, very important thing. This is always told to me by my guide, my teacher, Dr. Vijay Chava, sir, if he's in the audience or if he's listening. Thanks to you, sir. You always told us that soft tissue takes time. Give time and the soft tissue would respond well. Whether it's around a free gingival graft or a natural tooth or around a dental implant, it's the same. So this was a case where we did the implant, delayed implant placement along with simultaneous graft, some GBR there with an aesthetic buccal flap. So let's not look into this. So by the time the patient comes back around 4 or 6 months down the line, you see there is a contour deficit. There's a contour deficit at second stage. So at second stage, we decide to do palatal roll. Now, in retrospect, I shouldn't have done those release. Release incidents are now passe. You all do an envelope roll. So I go to the palate, release out the flap, roll it. This is a classical roll technique. Deepitalize the surface, buccal surface, which goes in. So you have connective tissue against the implant surface and the bone. You tie it so that it's stabilized. Those granules that you see on the surface, they need to be taken out. You cannot leave any granules there. And you suture. As I sutured this down, and due to the 2 dirty release incisions that I gave and use of these multi-filament fibers, you would see that when I restored it up, okay, I had a very big amount of recession. I had good thickness of the tissue, but my contour was not good. Okay, and even the prosthodont in the lab had made very wide. The cervical 1/3 of the tooth was far wider and not narrower. You have to understand this is a case that belongs to what we call as a high bioform, where the interdental papilla is literally at the junction of the middle and the incisal third of the teeth. Teeth are triangular. Every time I have to see or replace a triangular looking teeth, it's a disaster. Okay, it's very, very tough. So what we did was we under contoured this crown, we thinned it down to the way it looks here, and then left. We followed it, we forgot it. Occlusally, it looks good. And as we forgot it, 6 months down the line, when the patient comes back for follow-up, because it was under contoured now and the tooth looked more triangular-ish, the soft tissue started creeping. And as the soft tissue started creeping down, you can see that from the day when it was initially done to the day 6 months down the line, you see that the soft tissue has crept up. It has crept up, and now the gingival zenith on the lateral incisor is nearly at the same level of the central. Ideally, it should be more incisal, but it's okay. I would accept this at any point in time. If you see the adjacent contralateral, it's exactly the same level as 2-1. So what I'm now seeing is slowly over a period of time, if you have ideal tissue thickness, it would creep down. Okay, and what determines the creep? The creep is determined by the interdental peaks. If I have interdental bone peaks at a coronal level, then my soft tissue also will start creeping down. And why it crept in this case? It crept also for the reason that it was a pedicled graft. Because it had carried its own blood supply, there was no chance of involution of the graft. That's why the graft that was there was alive and active, so it could rapidly multiply and then start settling down around the tooth surface. So give some time to the soft tissue and you start seeing better outcomes. And that's why you also see a very stable bone level around this implant. The most common technique that we have to see around what we call as dental implants are palatal roll and finger split. Just a moment. Yeah. One of the most common ways to achieve wonderful soft tissue outcomes is by a technique called as palatal roll and finger split. Let's look at these 2 congenitally missing lateral incisors. The implants were placed, and then at the time of uncovering, on the 1-2 side, we just did a small semilunar incision here. And that semilunar incision was tagged and hooked onto the distal side and suture. So that's how you got the contour. On the other side, in the 2-2 side, you see that there is a considerable amount of buccal deficiency. And that's why we opened up the flap. We did the palatal tissue roll. So the top part, the palatal part of the graft of the tissue was deepithelialized, like what you saw in the previous case. And after deepithelializing, after the deepithelialization was done, the graft, one second, just put it back. I don't know why it's getting stuck. Yeah. After the deepithelialization, it is now rolled in and then sutured up. And along with that, the temporaries are inserted on the same day. So what happens is the temporary then supports the overlying soft tissue. And 10 days down the line, when the patient comes for suture removal, you see that the tissue is good. Over the next month, month and a half, you see that the tissue would start shrinking down and then conforming well. And as this happens, we keep on shaping the temporaries. And then eventually, once the final restorations are ready, this is the final abutments. And then on top of that, fit in your final restorations. Now, actually, you can see that on the side where we've done the tissue roll, a pedicle connective tissue, and on the side where we've not done that, you can see a stark difference in the amount of bulk of the tissue. Actually, now the 2-2 site actually looks far better than the 1-2 site. Okay, you can see that even in the contour. And now this is over a period of probably 5 years when the patient came back for follow-up. And that's what you see. The tissues look much better on the 2-2 side as compared to the 1-2 side. Next, we move on to free soft tissue grafts. Free soft tissue grafts are those set of grafts which you remove from one area and graft it into the other. One of the most common areas where you will have to do a free soft tissue graft is when you have pontic sites. Okay, so let's look at this. It's a 3-unit bridge. The one is undergone a root submergence, but the tissue is not covered up. So how do we cover up this? So you go to the palate, you take a free gingival graft, what we call a conventional free gingival graft. You leave the epithelialized portion at the top, and then the perimeter is de-epithelialized, and then you suture it. And as you suture it around, hold it, and then you do a final cementation of your bridge. And that's how it is. It's on the day of your final cementation. So till then, there's no grafting done. So you do the final cementation of the bridge. The graft that you placed would heal underneath this pontic. And now this is what it looks probably a few years down the line when the patient came back for follow-up. Now you see that in the root submerged area, you have a considerable amount of soft tissue thickness. You see the bulk of the tissue, and the pontic site looks beautifully emergent. Actually, now on the 2-1 site, where there was no soft tissue grafting done, you see the soft tissue is thinned down. That's what I keep on telling. Peri-implant tissue is a scar tissue. And as scars over a period of time shrink, the same thing happens with the peri-implant tissue. That's why it's important to have considerable amount of soft tissue bulk on day 1, so that at the end of 5 years, for example, if you have 3 mm bulk on day 1, 5 years down the line, it would probably become 2, 2.5. 10 years down the line, it may end up becoming 2. So you're always better off having good amount of soft tissue bulk around your implant restorations. That's how it looks. Let's look at this case. Again, congenital missing lateral incisors. Let's skip the surgical part, regular implant placement, and temporization. And then the final restoration. This is how it looked on the day we had done the final restorations, and after probably a month after follow-up. At the time of this, you see that the tissue around the implants look very good. The both the lateral incisors 1, 2, 2, you see beautiful stippling, and I thought it was excellent. What I had done was, when I was doing the implant placement along with simultaneous GBR, I'd use a titanium mesh. This girl comes back around 8 years after the graft. And when I see her 8 years down the line, you see that in the areas where I have the titanium mesh, okay, the mucosa started thinning down. And because of thinning down of this mucosa, now I'm scared where it would just perforate out. So before it perforates, I wanted to open out and take out those titanium meshes. So what we did was, we did a vestibular incision, removed the titanium mesh, and then tucked in. I wouldn't leave this surgical site without any graft. So we tucked in connective tissue on both the sides. You can see here on the 1-2 site as well as in the 2-2 site. In the 2-2 site, we had a small fenestration in the gingival margin. And so that's why the mucosa came out. The connective tissue is a bit exposed, but it was tacked and sutured on the either side. And 15 days down the line, the way it looked, 15 days or a month, at 1 month down the line, you can see that the tissue on 1-2 side, where there's no marginal perforation or fenestration, tissues look good, nice and neat, well stipulated, well settled. Whereas I was very, very depressed, very upset rather, that on the 2-2 site, we now have an area where you have a small amount of marginal recession. But because I had a connective tissue and I had a good amount of bulk in that site, what happened was, over a period of time, the tissue crept up. At 12 months down the line, as the tissue crept up, now you see that the 2-2 site has nearly the same amount of gingival marginal tissue as compared to the 1-1 site. Though the stippling is not as good because it was a creeping tissue, and unlike the far more attached tissue on this side, but the gingival or the mucosal levels rather on 2-2 and 1-2 are exactly the same. And why did this happen? It happened for 2 reasons. The role of the connective tissue, which increases in thickness. Secondly, is the peak of the interdental bone on the adjacent side. That gave a good amount of blood supply to this graft, and that's why you see wonderful amount of soft tissue thickness. And what you see is also the underlying bone levels on this area. It's absolutely stable at 9 years, and this is at 9 years post. You see here that the gingiva or the mucosa around both these implants look so beautiful. It looks emergent, the teeth look alive, and that's what we want. So this is a case where you do a free connective tissue graft much later in life of an implant. And this is at 10 years. One of the most important things in implant dentistry is developing the inter-implant papilla. And we know the Starnow's rule that if the distance between the apical most point of the contact to the crest of the bone is 5 mm, in 98% of the sites, you would get a papillary fill. If it's just a millimeter deeper, then it would, the success rate falls by 50%. And then if it is a little bit more, then it's just 25%. Okay. Very, very critical are adjacent missing teeth. So when you have sites with adjacent missing teeth and you are getting 2 implants in, it's very, very crucial that you also get the inter-implant papilla. If you don't get the inter-implant papilla, then you are struggling. You are struggling for aesthetics. And if the patient's got a high lip line and is very demanding, then it's a big, big task. What we did here was we had an implant, 2 implants, ideally placed. The inter-implant space, normally ideally, which is 3 millimeters. In this case, we put 4 millimeters. The inter-implant distance was 4 millimeters. Temporized. So this is day one at probably around a week after temporization, this around a month. And then slowly you use the temporary to sculpt the tissue. So the role of prosthodontics and temporization becomes more and more important as you want to start sculpting the tissue. It is a no-brainer to use a blade and chop the tissue off. You're always supposed to use a temporary to push the tissue away. Okay. And then eventually you select the best possible abutments at zirconia and then give zirconia crowns individual. Okay. So that's how it looks now. So between the 2 crowns, between 1.1 and 1.2, you have papilla. There is some amount of soft tissue reduction at the end of 1 year. This is at 5 years. You see the tissue is good. It's stippled. It's got thick there. And this is at the end of 8 years. You see that the papilla, the tissue, everything looks nice and neat around these implants. And I'm hopeful that it would eventually hold up. But if you actually give a more closer view, though the stippling has increased, you also see that there are small scar lines, a small reduction in the tissue bulk that's happened exactly at the gingival margin in relation to the central incisor. And this is what I again tell. The scar tissue around a dental implant, the peri-implant mucosa is a scar tissue, and this undergoes a continual reduction in bulk. So that's how it looked at cementation, where you had much bulk, less stippling, whereas at 8 years, you see the stippling has increased, but the bulk has considerably reduced. And so this site would probably, I would probably look at doing the soft tissue graft in this area probably 5 more years down the line from now. But the emergence and everything looks just fabulous. That's what we want. What about the inter-implant bone levels? They've been rock solid, stable, and you can see that. And that's the graft. Let's look at the next set of cases, which are far more tougher. This is a case, what I would call it as one of the most challenging cases that I've seen. A very, very young girl in whom we had done immediate post-extract, in whom we did extraction. We had done a cowrie block there. Okay. And then this is at the time of implant placement. Okay. So at the time of implant placement, we designed the incision in 2 ways. We had good amount of soft tissue bulk. So we made an incision there in the gutter. And this incision was divided into 2. So one would give access, open up the site, and then I would move the palatal connective tissue onto the buccal side. So then the second incision was done there. So we separated out the epithelium and some connective tissue, and then use the remaining connective tissue to take onto the buccal flap. So we actually took the palatal connective tissue onto the buccal. And as we do that, we also removed the screws of the block. We had the implants that went in the right location. That's what you see there. And then this connective tissue, which was underneath from the palatal side, which came to the buccal. It was pedicle. It was attached to the buccal flap in the papillary area and then thinned it down. We thinned it down so that we could now get two pedicles, which would now form the new inter-implant papilla and the incisive papilla. You understand when you saw the pre-op or at the beginning, there was no inter-implant papilla. It was just a flat ridge. Now I have to create an incisive papilla, and that's probably one of the most toughest things you can do. So what we did, we took the palatal connective tissue onto the buccal flap, and then it was not detached. It was left there to continue its blood supply and then thinned down so that you could then tie it up and create an incisive papilla. Because the primary stability was excellent on these implants, what we did was we temporized it immediately. This is how it looked when she came back for suture removal 10 days down the line. You start seeing some kind of papilla between the two implants and in the pontic side. 3 months down the line, as the implants integrated, a bit of soft tissue correction, contour correction. That's how the implants look. As the soft tissue contour was done, to get a bit more accentuation, we reduced, temporized it, allowed the tissues to heal around the temporaries. So the temporaries actually help in contouring the soft tissue margin the way you want, a bit more correction. And that's how it looked on the day we fitted her fine restoration. So shade match was not good, but patient was happy because she was far happier than what she was expecting. So now we have the inter-implant papilla, we have an incisive papilla. It's not a flat line there, you see? Between the two implants and the pontic side, it's not a flat line. You still have a scallop, and the soft tissue scallop, it is not done in pink porcelain, and that's important. And that's where our role as periodontists comes in, to get much more natural tissue contours as compared to using a flat prosthesis with pink contours. Very similar tissue again, similar situation, central incisors where we had done a Corey block. Let's skip through that. And when this patient came back for implant placement again, we did an incision. We had the implants went in some areas where the graft had not taken up. We did a volumax there, some graft. The stability was good, so the what we call the healing abutments went in at the same time. But as the patient healed up after the implant placement, you see between the two implants in the incisive papillary area, I had a big gutter. We have a big ditch there. And this ditch is a disaster because if you put a pink there, what's going to happen? It's going to entrap food, and that's not what I want between two implants. I do not want any food entrapment. I still want a papilla there. So what we do now, then we do a vascularized interpositional connective tissue graft, go to the palate, make an incision first on the palate, remove the epithelium, separate out the epithelium, take only the connective tissue and roll it. So the connective tissue now rolls between where the potential incisive papilla is and closed up. The healing abutments go back. So now I have generated a surgical papilla. And once the surgical papilla got generated, you can see here, this is on the day of suturing. 4 weeks later, I have a papilla, the depression, the ditch, what you have seen, that's gone. Now we start contouring it with the temporaries. For a period of next 4 or 5 months, the temporaries keep on contouring. We start getting the shape, we start getting the bulk. And that's how we have the final abutments. You see a very, very healthy peri-implant mucosa there. And that's how we have now metal-free restorations made in zirconia fabricated and zirconia fitted there. So what you see now is you have ideal emergence. We have a nice inter-implant papillae and a beautiful looking teeth for this patient. And what this does now, you see a good bulk, so that facilitates hygiene. You have a good amount of keratinized tissue that facilitates brushing, and a papilla that looks nice and neat. So that's what we have now in this patient. 1 week post restoration. Coming down to highly demanding patients, a very, very young girl with a missing central, broken lateral. You look at these situations and then you always scratch your head. Every time, even today, after doing implants for the last 18 years, every time I see a missing central incisor, I think a million times over. So let's look at this case. We did an implant first, then a bone graft, contour augmentation. It's not for hard tissue, but for soft tissue. Graft around, temporized. Temporaries always, if your implants are rock solid stable, if they have an insertion torque of more than 35, you can always load them temporary. Especially in the aesthetic zone, when you make good set of temporaries at the tissue level, you start building up the soft tissue from day one. On the day of implant, you start building the soft tissue. Now, 3 months, when the patient comes for suture removal, You see here, the tissue is healed well. You have the stippling, contour is already there. 3 months down the line, you remove the temporary, you start customizing your temporary for the impression post. So the lab exactly gets the same amount of form, the kind of emergence that you generated in the temporary, the lab gets same thing on the model. So now they can customize the abutment so that you can have the ideal emergence. So the emergence that you generated in the temporary is the same emergence that your lab is going to give you. Okay, so that's a custom-made abutment. That's the emergence. You see now the shape. An implant is round. Our teeth are pyramidal-ish. So when the tooth comes out of the implant, when the abutment comes out of the implant, it should look exactly as if it's emerging, and that's what you want to generate. And that's the role of the temporary comes into picture. Okay, and that's how this tooth looks when we fitted it up. You see a very, very healthy stippling around the implant, and that's what I want. I want to see a nice stippling. It indicates that I have a very healthy tissue there. And that's how it looks on the radiograph. Probably the last set of case, we have this patient here with a missing central and lateral. When you see the CBCT, it looks far more weird. She had a trauma. You see that due to the trauma, the teeth had fractured. Which part? The canine had fractured, in the lateral had fractured. The palatal part was attached to the bone, the buccal was out. You see the canine apical third and mid third had fractured. 2-1 had completely, the 2-1 had completely gone out. Okay. So what we did was we took the tooth out, we did a dentin graft. Okay. So conventional post-extraction placement was done in 1-2 tooths. You can see here now, the implants went in. We did an aesthetic buccal flap. I didn't want to make an incision at the top and lose the tissue. So we did an aesthetic buccal flap. One of the easiest approaches to remove the roots, if you have, is to do an aesthetic buccal flap. Do not try and make a big envelope from the crest, open the whole curtain and try and remove the root. No, you can just make a small incision at in the vestibule, and then you can literally tap it down. The root, what is fractured, you just tap it down. So you do what we call as a aesthetical buccal flap. So this palatal sheet of root that was remaining was opened through that incision. The same piece of tooth was then crushed down and then made into autogentine bone graft. The implant went in, the dentin graft went in, then the membrane to cover the graft. Okay, now because we had extraction sites there, okay, and I already had made an incision in the aesthetic, I still had to close those extraction sockets. Okay, doing a palatal roll was out of question because I could not advance the flap so much. So what we did was we did a free graft. So what we did, we took a free graft and then sectioned into 2 parts. One part which went into the bulk, making the bulk, was de-epithelialized. The other part was epithelialized. So that part which was making the bulk went underneath the buccal flap here, okay, to cover that aesthetic opening, the vestibular opening, and then the epithelialized part closed up as a lid in the socket. So one chunk of graft harvested from the palate as a free gingival graft, you de-epithelialize one, tuck it underneath the buccal flap, forming the connective tissue there. You keep the epithelium intact and forms the lid of your extraction socket like a socket seal. So what we did now was you used the same graft as a composite graft, epithelialized as de-epithelialized, but a free graft and not a pedicle graft. So that's how it got closed. This lady got closed. You can see now on the CBCT, the dentin graft, the implants in the right location. There are healing abutments. There are no cover screws. The advantage of putting a healing abutment is it gives you additional soft tissue. And then if you want, you can chop it off, or you can leave it there. So that's how it looks 4 months post. The dentin graft looks well healed up. Now you see here that the ridge is flat. The allular ridge in the area where we have the implant is absolutely flat. There's no contact site, there's no scalloping, there's absolutely nothing, just one flat line. Okay, but what I want is a shape. So what we do now, because I had the healing abutments in place, what we did, we just did a small neck opening, took the healing abutments out, and then we custom made a temporary. So we made an impression of the implants, had the lab make temporary, and this temporary went into the implant sites. And in the pontic areas, in the 2-1 and 1-1 area, The Pontics also had the projection so that they would then start creating a Pontic site for emergence. So that's how it got fitted. Okay, and this dimpling was slowly contoured over a period of time. And that's what you see. 3 months down the line, the patient had this temporary. It was kept on modifying every second week. We used to modify, add or remove as per the contours requirement. And this is how it looked on the day we were going to make the final impression. So we now have ideal emergence on the 2 implants, the lateral incisors, and 2 Pontic sites, which are beautifully made in the 2 central incisor area. So instead of using a regular impression, now what we did is we wanted to transfer all what we had generated on the chair side to the laboratory to make the count. So we use the temporary itself as a impression coping, a customized impression coping. So remove those small fixation screw, use the long screws of your open tray impression post, pick that up, and by the time we had the master model ready, now what I have a beautiful emergence on the 2 implant side, and I have 2 beautifully trapezoidal contoured 2 central incisor sites where my lab will give me the same emergence. And you can also see we have a beautiful papilla now between the 2 implants and also between the Pontic sites and the implant sites. So the lab will now give me a beautifully made restoration. This case has not been restored. So I'm just showing that how you can work on the hard and soft tissue using gingival formers at the time of implant placement to get additional soft tissue height, and then customizing the temporaries and contouring it out. This is a case, it was a student of mine, very demanding patients, obviously, and the stress on the clinician or the teacher when you treat your student or your teachers is very, very high, because you don't want to be looking a fool or a poorly skilled person in front of your own students. You know, it's very demoralizing for the student that my teacher doesn't know anything, you know? And it's not good. So this was an ankylosed 2-1 which was resolved. Okay, that was some soft tissue planning. This patient, student of mine, had undergone some orthodontics. He had altered passive eruption. So we had to correct the soft tissue height, soft tissue bulk, as well as get the implant in. So we planned the soft tissue reduction first. So we did a template. And as per the template, the soft tissue excision was done. After the soft tissue excision was done, the implant was placed, some GBR was done. Okay, and the site was temporized. Again, instead of the healing abutment, we had used a shortened milled abutment so that I have additional soft tissue to play with. 3 months down the line, I have a decent contour on those teeth, but I'm still not happy. You see the buccal thickness of the tissue has come down because of shrinkage. So at phase 2, when I was doing further correction, we did some more gingival excisions. Then you see now we gave the first temporary. The first temporary, what has been placed on the implant looks having the soft tissue recession. There's soft tissue recession in relation to the implant site as compared to the adjacent site. You can see that it's nearly 1.5 millimeters to 2 millimeters. So what we do is we follow a technique called as the dynamic compression technique. I'll just play the slide back. So we do a dynamic compression technique. What's a dynamic compression technique? It's a technique where you take the temporary, you push, remember this word, dynamic compression. So you take the temporary, you push it, the soft tissue against it, wait for 3 days, not more than that, wait for 3 days, and you remove the temp and you under contour it. Due to the pressure, the inflammatory process that is set in due to the pressure, okay, will start reacting and you start getting a highly fibrous overgrowth. And at the end of 3 days, when you under contour it, the soft tissue will start growing back at the end of 1 week. So day 1, you over contour it. 3rd day, you remove the temporary, you under contour it, and then you fit it back. And 1 week down the line, what you see is this. Now, what I see here around the 2-1 is basically a reactive hyperinflammatory tissue, okay, around the under contoured 2-1 crown. Okay, now it looks my tissue is good. I then keep on under contouring it a little bit more so that the tissue starts settling well. So there's no graft done here. What we did was we played with the tissue to give the kind of outcome that we wanted. So that's how it looked on the day we were doing the final restorations. This is at the final restoration. You see that we now have a very nice ideal contour, the shape, the bulk, and everything else around this case. So with this, I would like to conclude my online presentation. on soft tissue procedures around dental implants. I would look at going back to these things that I want you all to remember. The must-know things. The must-know things for every student would be the various types of biotypes here that you see. Also, how do you evaluate the biotype? It's not just for perio reasons and also for implant reasons and aesthetics. The next thing I want you all to know is what's a bioform, and that would determine a lot about your surgical decision making. Apart from that, yes, the factors that I would want you all to remember is this. I want you to remember the properties of a peri-implant tissue and how and why they are far more different than a peri-implant tissue. You will get a lot of information regarding the biological hemidesmosomal attachments, etc., from your textbook. Whereas what's important is understanding why it is different. You know the data is there in the book, but understanding why it is different is important. The points of difference is there's no cementum, there's no attachment to the tooth, there's no attachment to the dental enamel junction, cement-to-enamel junction rather. Okay, and there's no attachment between the fibers on the bone to the tooth. That's why the tissue, what you see on a dental implant, is adapted tissue. Some people say attachment, but no, doesn't exist. Okay, and it's a very, very closely adapted tissue. So you need to know the entire set of differences between a soft tissue on a dental implant and soft tissue around a natural teeth. That's why the difference is peri-implant tissue is known as a mucosa. Peri-implant tissue around the natural teeth is known as gingiva. Also important to know is critical soft tissue thickness. What's important to guard the marginal bone levels. Okay, and that value is 2 millimeters. If you have 2 mm or more, then it would guard the bone. Anything lesser than 2 mm, then you would end up with losing the bone around your dental implants. And depending upon the amount of bone thickness, you are going to see the kind of bone loss pattern. Either you're going to have what you call a horizontal bone loss or angular bone loss around the dental implant. Okay. I hope you're understanding that. 2 mm or more, no bone loss, stable bone levels. Lesser than 2 millimeters, if the bone volume around an implant is higher, you'll have angular bone loss. If you have a bone volume that is lesser, you'll end up with a horizontal type of a bone loss around your dental implant. Okay, if the soft tissue bulk is less. And that's why it's important to know that. What are the parameters I as a clinician look at? Are these, remember the same 7 parameters that you see on a natural tooth. When do we intend? You can intervene at any point of time in management of soft tissue and dental implants. The nature of classification, both epithelialized and non-epithelialized, pedicle and free. And these 2 studies are classical. Please remember that. Along with that, I'd also remember you to read on Thomas Linkovicius' article on soft tissue around dental implants and the importance of vertical soft tissue thickness. Okay. With this, I would like to conclude my presentation. If you have any doubts, I am easily available on Facebook. That's my name there. Email, and you can contact me on this one. Thank you so much, everyone, for your patient hearing. And I am present right now online to take questions. Thank you so much. It's been a pleasure. Thank you.